On May 22nd, the preliminary results from a 60-site international trial involving 1,063 patients with advanced COVID-19 were published in the New England Journal of Medicine. These patients were randomized to either 10 days of remdesivir or placebo, and those who got remdesivir had a median recovery of 11 days versus 15 for placebo. But let's take a deeper look and make a brief critical appraisal of this evidence.
First, this trial is a prospective, randomized controlled trial, and patients and their physicians were both blinded, meaning they did not know who got remdesivir or placebo. Blinding removes significant bias because if a doctor knew which treatment group a patient was in, the doctor may make different treatment decisions. Likewise, patients may report subjective symptoms differently if they knew which group they were in. The quality of evidence from a double-blinded, randomized controlled trial is significantly stronger than the anecdotes about a patient or a group of patients or a report made in retrospect. Because the trial was randomized, the group that got placebo was similar to the group that ended up getting remdesivir. Randomization removed selection bias. If we did not randomize, the patient who got remdesivir or placebo may have been sicker or healthier to begin with, which then makes the data difficult to interpret. One major caveat of this study is that it's still ongoing. Clinical trials have safety monitoring boards who review results. Since the study enrolled the necessary amount of patients quickly, they started having enough results before complete follow-up of all patients was fulfilled. However, given the findings of the preliminary data available at the time, the board felt that this needed to be public to help clinicians make decisions about using remdesivir. Since patients are followed through day 29, data collection is therefore still ongoing for those enrolled later. In the discussion section of the manuscript, the authors noted that they reviewed the Q outcomes and mortality results as of May 18th, 4 days prior to publication, and they said these were, quote, similar, end quote, to the reported results from April 28th. So let's break down the results. Is improving 4 days sooner a clinically meaningful benefit? That's a subjective question, but let's first define what they mean by improvement. Patient status was measured on a 1 to 8 scale, with 1 being not hospitalized and 8 being dead. Every patient started with a clinical status of 4 through 7, which means they were hospitalized. If we access the supplemental appendix to the report, the majority of patients needed at least some sort of respiratory support, all the way from oxygen alone to mechanical ventilation and ECMO. Time recovery was defined as the first day, within 28 days of enrollment, that a patient improves to category 1, 2, or 3. In other words, the median time to recovery to discharge from the hospital or being in the hospital but no longer requiring medical attention was 11 days in the remdesivir group and 15 days in the placebo group. For most people, though, the most meaningful outcome is mortality. Does the drug reduce the risk of death? Statistically speaking, no. What do I mean by that? Since we can't give the drug to every hospitalized patient in the world with COVID, we don't really know the, quote, true death rate of people taking this drug that have COVID. So we use a sample to represent the general population. As we know, samples inherently have some error. I'm way oversimplifying statistics here, but for the purpose of this video, we can mark this uncertainty with brackets, representing the 95% confidence interval. That means if we were to run the same exact experiment 100 times, in 95 instances, the death rate would be within these brackets. By convention, a result is statistically significant if the 95% confidence intervals between the experimental and control group do not overlap. This is where sample size matters. If you have a bigger sample, your brackets of uncertainty or confidence intervals shrink. If the difference is big between the true rates, you don't need to have big of a sample size because the brackets can be wide and still might not overlap. However, to detect subtle differences, such as a few percentage points in mortality rates between two groups, such as in this case, you need a large enough sample size to make the brackets more precise. This is the concept of statistical power.
So which patients can we apply these data to? Based on this study, the strongest evidence is for non-ICU patients who need oxygen. This is based on a subgroup analysis of patients based on their initial clinical score. In this plot, the confidence interval bracket is clearly demonstrating remdesivir is better for people who start with a baseline score of 5. For those with a score of 4, it is not statistically beneficial as it crosses this line, but this may be because there's not enough sample size. For patients who start this drug already on mechanical ventilation or ECMO, there's not great data saying that this drug will help. So how do we interpret all of this? Given the available data, it appears that remdesivir does have some benefit. These results should be enough to make remdesivir the standard of care treatment in hospitalized COVID patients who meet criteria, since it appears that patients will either be discharged from the hospital sooner or at least no longer require hospital-level medical care. Whether or not, as the final data comes in, this reduction in death ever becomes statistically significant, I think we can confidently say that this drug is not going to be a silver bullet. It is a first tool in an all-too-empty toolbox to treat this vicious disease. The goal of my videos is to break down complex medical subjects for the non-medical public. I'm trying to make it at least a little bit more easy to understand. If you like this content, please subscribe and leave a comment below.